Good morning. This is from Madras Medical Mission, Chennai. I am Dr. Shivakumar, heading the Pediatric Cardiology Division, and with me is Dr. Tejasvi, who is our Senior Fellow. Dr. Pramod Sagar, who is the consultant, will be presenting a short detail about this patient who has got a very interesting clinical situation. Over to you, Dr. Pramod.
Yeah. Welcome everyone. Our patient is a 4-year-old boy. He is a known case of transposition of great arteries with a small destructive VSD, ASD and a large PDA, who was diagnosed at birth and was on prostaglandin infusion to maintain the patency of PDA for duct-dependent circulation. Then he underwent a arterial switch operation at day 7 of life. During the surgery, as you can see here, the aorta and PA, the aorta was arising from the anterior RV and PA from the posterior LV, so the aorta and PA were transected, and the PA was brought forward to anastomose into the RV by a Lecomte maneuver. That is, the PA was brought anterior so that the aorta can be pushed posterior, and the aorta was then anastomosed into the LV. This is how a Lecomte maneuver is done. So the PA will be anterior and the branch PAs will go by the side of the aorta before reaching the hilum. So the patient was doing well, and on routine clinical follow-up, he was doing well, but the examination showed there was a grade 3/6 ejection systolic murmur in the left upper sternal border, which was significant and it was progressing. This is the ECG, which shows normal sinus rhythm with an axis of +90 with prominent right ventricular forces. This is an X-ray which is not much remarkable. There is a mild RA enlargement. There is no significant cardiomegaly. CTR is 55%. Otherwise, nothing major in the X-ray. Echocardiography. If I have to tell about the echocardiography in a patient with arterial switch with a patient who has undergone arterial switch operation after post-Lecomte, the imaging of the branch pulmonary artery becomes difficult. Here we can see that this is a frozen image. This is the aorta and this is the anterior MPA, and this is the origin of the branch PAs, but it's difficult to image because it is completely anterior and they are difficult to image by echocardiography alone. However, we could find that there was a gradient of 80 mm across LPA and 70 across RPA by echocardiography. So we did a CT. This is a CT which shows the Lecomte. This is the anterior MPA, this is the posterior aorta. This is the RPA and this is the LPA. We can see that the RPA has significant narrowing where at the point of contact with aorta, and also the LPA has significant narrowing here. The hilar RPA is good sized and the hilar LPA is marginally smaller. However, the narrowing was quite significant, and RPA narrowing was around 3 and LPA was around 4 mm. This is the reconstruction which shows better actually. This is the anterior MPA and this is the branching of the MPA into left pulmonary artery and the right pulmonary artery, and this is the posterior aorta. This is the anatomy after a Lecomte, where we can see that the MPA divides and the RPA and LPA will go by the side of the aorta. When we slice it, we can see here that the MPA bifurcation is fine, but as the RPA origin begins, there is narrowing that begins from the RPA slowly, and the RPA is significantly narrowed here. However, the RPA hilum is good in size. Again, LPA, if we see, LPA is again narrowed in the whole length, and this is the hilum. So this is like a virtual stenting, how it can be done. Like the plan is to, like virtually we stented both the branch PAs, and if we stent it, we will see that the stents will be not in contact with each other, both are a bit far from each other, and we will be able to achieve a good relief of obstruction. The branch PA stenosis after this arterial switch operation is a common complication that is known and varies from studies, and it vary from 7 to 40%. And this is one of our patients who is presenting now with branch PA stenosis, who is having increased RV pressures. So we have taken him for an intervention. Thank you.
Thank you, Dr. Pramod. That was a wonderful virtual reality image that you have shown, and what we are seeing is the main pulmonary artery located anterior to the aorta, and both the pulmonary arteries are going around the aorta, and so they get sort of stretched, elongated, and in this process they get into bilateral pulmonary artery narrowing. It's quite common problem that is seen in post-arterial switch operations where there are some issues in management. Number one will be, even if you do a repeat surgery and enlarge those pulmonary arteries with a pericardial patch on both the sides, the problem remains because the pulmonary artery still will remain stretched by the dilated aorta. And so there will be recurrence of a narrowing. The issue about stent angioplasty of the pulmonary artery will be, since there is a close relation between the ascending aorta and these branch pulmonary arteries, they carry a small risk of erosion of the stent from the pulmonary artery into the ascending aorta, causing an aortopulmonary fistula. Of course, we probably will not be aiming at enlarging it for a very, very, very large diameter. What we are able to appreciate on your virtual reality image that I am seeing on the screen is that the hilar right pulmonary artery and hilar left pulmonary artery are good in size. And what we have is a sort of a stretch elongation of both the branch pulmonary arteries. As you precisely told earlier, previously, before the surgery was completed, the pulmonary artery is posterior and the aorta is anterior. So the pulmonary arteries were having a short course towards the hilum. But once the pulmonary artery, main pulmonary trunk is brought anterior, it gets stretched enormously. So in this procedure, we have, as I previously mentioned, Dr. Tejasvi, who is assisting me, and Sister Christy is our scrub nurse. Prabhu and Surya are our radiation technologists, and Dr. Uday Charan, who is our intensivist, who is managing the patient with a small dose of dexmedetomidine running. The patient is unconscious, sedation, breathing spontaneously, and as I speak to you, the saturations are around 100%. We did a little bit of preliminary work. We took a right femoral venous, right femoral arterial axis, and left femoral venous axis. There are two venous axes that has been taken in order to facilitate bilateral pulmonary artery stenting, so that one sheath will take care of the right and one for the left. And there was a doubt about a small residual ventricular septal defect, and hence we have taken an arterial line. So the arterial line is also in place for us to do an elective left ventricular angiogram if there is a need. What we did was advance a catheter from the right atrium into the right ventricle and the branch pulmonary arteries. I'll show you the fluoroscopic image. So we have now two catheters. The right femoral sheath has got an 8 French sheath that is running in the right ventricle. And from the right ventricle, there is a marker pigtail that has gone deep into the right pulmonary artery. And in the pressure tracing, what we see is the right ventricular pressure of around 85 to 90 millimeters of mercury. And the pulmonary artery pressure is somewhere around 30 to 35 millimeters of mercury. So there is a significant gradient between the right ventricle to the right pulmonary artery. The pigtail catheter is deep in the right pulmonary artery.
So some basic questions to discuss, sir.
Yes.
So you explained like you are taking two venous axes for facilitating bilateral PA stenting. So what will be the problem if only one of the branch PA is stented and the other is addressed after stenting, that like recross again the other stent and other artery and stenting again?
Can be addressed that way also. Actually, since the problem here is not involving the confluence, we can address the right pulmonary artery initially, followed by left pulmonary artery. That is also an option. However, if the right pulmonary artery origin is also involved, then you have to precisely position the two stents in such a way that the right pulmonary artery stent does not protrude towards the confluence to hinder our way of entry into the left pulmonary artery. In this particular patient, when you are showing the images, the narrowing of the right pulmonary artery and left pulmonary artery were right from the origin itself. And hence, thought it may be safer to have two sheaths so that we can position the two stents, check that both are not going to be interfering with each other. That means we are basically going to form a carina from the pulmonary trunk into both the branch pulmonary arteries. The stent of the right should not come into the path of the left. So we may be able to position the stents better if we have bilateral venous access. And as I speak now, we have connected the left pulmonary artery and the right ventricle. So once again, we have close to about 40 to 50 meters of pressure gradient. What we see on yellow in the hemodynamic trace is the left pulmonary artery, and the red is the right ventricle, which is recording almost a pressure close to 85 to 90. So now I am going to record a right ventricle and ascend and femoral artery pressure. This will tell us how much is the aortic pressure in relation to the right ventricular pressure. So this is a comparison of the aorta to, so this is aorta to right ventricle. The aorta is about 20 millimeters more. Almost the right ventricular pressure is coming close to the ascending, coming close to the aortic pressure. And aorta, as I speak, is around 105 or so, and the PA is around 85. So it's indicating that the RV pressure is quite significantly elevated. If you look at the indication for an intervention in a pulmonary artery stent angioplasty, especially when it is bilateral, a gradient of more than 50 millimeters of mercury, or if the right ventricular systolic pressure is more than 2/3 of the aortic pressures, these are all indicator. And here clearly we can say that right ventricular pressure is almost more than 80% of aortic pressure, and hence this warrants intervention. If you don't intervene on these patients, the distal hilar pulmonary arteries do not grow well, and so this will result in lack of ability to adequately achieve a good lumen of both the right and left pulmonary artery if we delay the intervention quite significantly. This child is somewhere around 4 years of age, and so I think probably this is a good time to intervene. What do you think?
Yes. And
so now let us go on to angiogram. We have positioned our catheter across the right. I'm going to withdraw the right pulmonary artery pigtail and probably give an angiogram.
the view, what is the view you are choosing for angiograms in this case, sir? In a patient with LeCompte like this, what is the better view?
Yeah. So the basic the pulmonary artery here will be coursing from anterior to posterior, as well from the midline towards the right. So we'll give a right anterior oblique for the right pulmonary artery and left anterior oblique for the left pulmonary artery. The marker is there to guide us little bit more. Yeah, that's enough. That's enough. To collimate a little bit. Nicely collimate. Yeah. So, what's the weight of this patient? 25. Yeah, 15 ml at 15 rate should be sufficient. Let's see this picture for the right. We will measure the right, and then we will probably introduce this marker pigtail onto the left and make another angiogram. Are we ready for the angiogram? 15 ml at 15 ml per second rate and around 1000 psi. Ready? So it's quite a significant narrowing, and we can find that a lot of the contrast is actually going distally. Freeze the image and show the narrowing. Yeah, so that's the narrowing. I'm going to advance the catheter into the right pulmonary artery, advance my sheath, and make an angiogram here through the sheath with my hand, so that I get an angiogram of the entire right pulmonary artery. Okay. So if you look at it from the marker, we have 3 markers across the entire length of the right pulmonary artery. So probably the length of the stent needs to be somewhere around 30 millimeter. Do you agree?
Yes, sir.
And then let us make some measurements about what is the size of the hilar pulmonary artery as well as the mediastinal pulmonary artery. It is the proximal 15 millimeter that is significantly narrowed. So we will have a look at it. So right now what we'll do is, let us get the thermo wire. We'll go deep into the right lung. Come to AP projection, please. So I'm taking out this marker pigtail. I want the right coronary artery catheter next. Basically an end hole diagnostic catheter to go deeper into the right pulmonary artery. So I have taken out the marker pigtail catheter and I have gone with the 4 French Judkins right coronary catheter. Hold the wire. So now at this point we'll change into an Amplatz superstiff guide wire. So this Amplatz superstiff guide wire will be our workhorse for the stent angioplasty. Once I position the catheters, then we will take some measurements and then take a decision about, already it looks like the length of the stent needs to be about 3 centimeters. We need to decide about the diameter of the stent.
Regarding the angiographic projections, we know that in this case actually the confluence is safe, the confluence is not having significant narrowing. If the confluence was also narrowed, what kind of angiograms would show it better, including the branch case in these cases?
One of the challenges that we'll face in the presence of a confluence narrowing in a setting of an arterial switch operation is that the confluence will be narrowed anteroposteriorly and not so it's going to be difficult in visualizing the confluence very clearly. It's going to be anteroposteriorly be compressed. So we may need an extreme steep caudal or extreme steep cranial, the point of 45-degree cranial or a 45-degree caudal, in order to get good quality pictures. So here, the sheath seems to have gone inside okay, this is the, freeze it. Okay, just go back. Okay, just one frame before. Okay, so that delineates the RPA origin. Let me see the pressure at this point. Keep the door closed. Okay, so this is the pressure in the distal main pulmonary artery. You can see that there is a sort of ventricularization of the main pulmonary trunk pressures because of the peripheral pulmonary artery stenosis. The main pulmonary artery is showing a high systolic and a low diastolic, suggesting the peripheral PS. Now we'll take the thermovire and go deeper into the left pulmonary artery. Here you see, Pramod, the left pulmonary artery narrowing is not getting visualized. It's more, it's seen more in the mid left pulmonary artery. Can you see that?
Yes.
So let us see how on an LAO projection this angio looks. Trying to go into one of the lateral branches. Let's try here itself, okay.
Even in the CT, when we see, though we could recognize that there was RPA narrowing in the angiogram when we showed here, this RPA narrowing is actually, the RPA at that narrowing is actually oval in shape, and whatever we saw was the vertical component of the oval rather than the short like the narrower, the shorter axis of that oval. So it is even more narrowed than what we saw in the angiography now.
Okay, so you mean to say that the narrowing was more in the more anteroposteriorly?
Yes.
So it was like a oval lumen.
Yes, sir.
Right?
Even on the left side, it was the same. The compression was like it was like a oval narrowing. So
this is sort of flattened profile that we are getting.
Yes, sir. Yes, sir.
I agree with you. I think that is where the importance of a three-dimensional imaging is very vital. So here what we are going to do is take this catheter all across the left pulmonary artery. We have gone deep into the left pulmonary artery. So at this point, I'm going to make a sheath angiogram so that we, can you go to the left anterior oblique view? Just no, without any cranial, just a plain left anterior oblique. Yeah, go steeper. Yeah, that looks good. So here we are going to appreciate what is the length of the left pulmonary artery as well as the okay. There's an overlap, but still we are able to visualize the entire left pulmonary artery nicely. We will, before making some measurements, let's get a better quality angiography. So let me put in the right coronary, Judkins right coronary catheter once again and change it into another Amplatz superstiff guide wire. And be ready with the second 8 French flexor sheath for the left as well. And following this, I need a Amplatz superstiff guide wire for the left.
the sheets that you are using are braided sheets, right, sir?
Yeah, in order to prevent any kinks in the pathway, it's a good idea to use a braided sheet so that there are sharp bends from the most anterior main pulmonary trunk to the left and the right pulmonary artery. I have taken out the catheter and now we are going to advance an 8 French flexor sheath. A small blade. Yeah. Yeah, go inside. Yeah, keep going. Okay. So now I'm taking out, we're holding the sheath. I want again the marker pigtail here. I want to make a second angiogram into the left pulmonary artery in order to see the length of the left pulmonary artery. Contrary to many other interventions that we were doing, promote for this med stream, today this is a total pediatric intervention.
Yes, sir. Yes.
Which is in a small child, and this problem is going to be faced only predominantly by the pediatric cardiologists across the world. So I'm advancing the marker pigtail. Basically, this marker pigtail is not going to be injecting the contrast. I'm going to inject through the side arm of my. Show me the previous angiogram. The marker pigtail only guides us
There was
by
some more.
telling the length.
Should we change any view since there was some overlap in the previous angio?
But now that I have gone a little
Okay.
inside,
So the contrast will go only into the left now.
I hope so. Let's have a look.
Yeah.
Can you freeze it? Okay. Okay. I think we have a reasonably good quality image. It looks like the left pulmonary artery may need even longer stent. It may need almost like a 4 centimeter. Let's make some measurements. So let me, sister, I want the dilator of this sheath.
However, even in this angiogram, it appears like there is no significant narrowing because it is we are seeing the.
But it was diffusely hypoplastic. You see that?
And the LPA is diffusely smaller.
Correct. Correct. Diffusely smaller, and we already know that it is a sort of oval configuration. Yes. And hence what we are seeing is the larger dimension of the oval, and the smaller dimension of the oval is in fact perpendicular to this. Yeah.
So what are the kinds of stents that are suitable for this branch PAs?
Well, no, it may not be 8.6. I think it's a little over. We have to reduce it. Yeah, the correct. The stent is sort of hugging the lower border also needs to be taken inside. Okay, and make okay. That's fine. Save this image. The next picture was better. Yeah. Let's make a measurement here. I want the dilator of this right also.
If we come back to the question again, sir.
Yep.
Like what are the qualities of the stent for a branch, like which would be suitable for a branch PA?
Yeah. Now, one of the most important characteristic for a pulmonary artery stenting is that since we are doing it at just 4 years of age, it should allow re-expansion of the stent to a larger diameter when the child is growing and the somatic body growth increases. So for that, we need to be sure that the stents are post dilatable. So if you look at traditionally the Palmas Genesis XD stents, which are stainless steel stents, have been the most time tested ones. Similarly, the intra stent Mega LD, LD Mega or LD Max, they have been traditional stents. The problem about these two stents are that both of them are stainless steel. So once you put in a stainless steel stent, the ability to interrogate these patients with magnetic resonance imaging in future is going to be not good. So fortunately now we have two other types of stents. One is the platinum iridium stent, that is the Cheetham platinum, and the cobalt chromium stents. These are two stents that are the newer stents. Having said that, a large majority of pulmonary artery stents are still done with stainless steel stents. Now, in this particular patient, if you look at the anatomy, we have the hilar right pulmonary artery was measuring around 10, and even though the measurement is 19.6, I feel it's not correct because the marker itself is running 3 centimeters.
Yes, sir.
So we need probably a 3 centimeter stent on the right pulmonary artery. This length is sort of foreshortened. We are able to appreciate that the markers are 3 full markers are there across the entire right pulmonary artery. So we need a stent that is about 3 centimeters on the right, and which can be dilated, which can go up to say around 10 or 10 millimeter. The options for us are trying out a cobalt chromium stent which we have to mount on a balloon, or we can use a pre-mounted formula, Cook formula 1030, deploy it and then post dilate to around 12. I think we'll go for the second option, a pre-mounted stent, and then go for a longer option. Let me first get the stents deeper into the pulmonary artery. So now I'm having the right pulmonary artery stent.
Sheath.
Sheath.
Planning to advance the sheath. Now.
Advance the sheath. So we've gone across the right pulmonary artery, holding the sheath. And similarly, I'll make an advance into the left pulmonary artery. Holding. So we can see both the pulmonary artery, the distal pulmonary artery. Okay. The distal pulmonary artery pressure is so non-phasic, like almost it's becoming non-recordable. Okay, now shall we plan the stent? On the right, we are going to take a 10 into 30 formula. We'll deploy a 10 into 30 formula and then post dilate it into a 12 into 2 Mustang balloon. So this is a 10 into 30 Cook formula stent. The advantage of this stent is that it can be post dilated in deflator. This can be post dilated to a larger diameter. A 10 millimeter stent can go up to a maximum dimension of close to 18 to 20 millimeters. This is a stainless steel stent. It has got a 035 lumen and it's a balloon pre-mounted stent. The advantage is that it is very low in its profile, and so the profile of the stent, it can go through a 7 French sheath. The stent comes with its own balloon. There is a protective sleeve for the stent. So this is the protective sleeve. So this is the actual stent. So it's a 3 centimeter, right? 10 into 3, no? And the chart says that if I inflate it up to 10 atmospheres, it goes to a diameter of around 10.5 millimeters. So we are taking the right pulmonary artery stent now. There's a small tip here. Whenever there are bilateral pulmonary artery stents and when we are taking two separate stents across, frequently the operator will get confused about which sheath is through the right and which sheath is through the left. So in general, I try to put right femoral artery venous sheath into the right pulmonary artery and left into the left, so that that confusion is avoided. So now I'm going with the protective sleeve. I'm advancing the stent through. Can we go to that right pulmonary artery projection so that we... No, it's fine. So this was the projection that we saw. So there is a clip on the beginning of the right pulmonary artery, a metallic clip. We'll try to see. Are we in the same view? Yep. Yeah, we are able to see the clip now. I'm just advancing the stent a little deeper. And I'm peeling back the sheath about 75%. I'm still recording low pressures, which indicate that my sheath has still not come out of the tight region of narrowing. So I will come back a little bit. I'm still having low pressures. At this point, I'm going to check one angiogram. So I have to come much more proximal. So with the sheath, under pressure guidance, I'm coming out a little bit more. We are getting more and more pulsatile trace at this point. And I'm peeling back the sheath in order to expose the stent fully. Going to make another angiogram.
No.
We are positioned well.
This position looks nice.
The only thing is that we should not milk the stent. Milk the stent into the hilar portion of the pulmonary artery. So let us try to keep that metallic marker as our guideline, metallic clip as the guideline. And I'll peel back the sheath now. I'll just make one more angiogram now. Yeah, the position seems fine. So you can slowly start inflating.
I'm starting to inflate now.
Yeah. Yeah, keep inflating. Keep inflating.
Yeah.
Go up to
we go
10 to 11 atmospheres.
atmosphere, 10 atmosphere, and 11 atmosphere.
Now we can deflate. Fluorostore this and show us again. So this is the expansion sequence. So our proximal end of the stent is remaining proximal to that metallic marker throughout. Yeah. So let us see the position now. Okay, we seem to have fixed. But if you look at it, the distal part of the valve needs to be flared a little bit more. So at this point, what I will do is I will use the sheath to enter into the okay, hold the sheath.
Should I inflate a bit?
No. So now I need a 12 millimeter Mustang balloon. We have deflate. Have given a negative?
2. Negative. Fully negative.
So the balloon comes out. Fluoro. 50% of my sheath, this sheath is within 50% of the stent. So when the next balloon is going through the stent, it's going to be partially be protected. So this is a Boston Scientific Mustang balloon, 12 into 2, right?
12 into 2. Some people follow like simultaneous inflation of stents on both the branch PS. What is the benefit of that, or and what are the problems with that kind of technique, sir?
If you are completely involving the confluence, something like a Y stenting, then you need to be inflating simultaneously, because the stent on the right pulmonary artery ostia may encroach onto the ostia of the left pulmonary artery and may prevent recrossing of the left pulmonary artery. So in those cases, we may have to do, okay, first we will target the distal left pulmonary artery and then come to the proximal left. I will unsheath. Okay, now can you inflate first?
Yeah, inflating.
Yeah. Fully inflate.
I'm going to 6 atmosphere, 8 atmospheres, 10, 12, and 14 atmosphere.
Okay,
no?
deflate, fully deflate. So we probably should have fixed the distal part of the stent now. Fluorostore and run this again. So this is the distal part of the stent being inflated. So probably we are inflating the distal about 15 millimeter. Now we have to come to the proximal part.
There is also an opinion about hyperperfusion of one of the lung when one is stented and other is not stented immediately. So what is your thought process about
Correct.
that?
There can be a problem. That especially if it is a very severe stenosis causing extreme oligemia, it can produce hyperperfusion lung injury. That's another very important point that we need to be aware. So at this point, we are going to inflate the proximal part. Can you inflate it now to?
And going to inflate, going up to 6 atmospheres,
Yeah.
8, 10, and 12 and 14 atmospheres.
14. Okay. Now we can deflate. Since the proximal part of the balloon is actually occluding the main pulmonary trunk itself, there is a brief drop in the cardiac output. Now it has recovered. So this is on the right. Now we will take out this balloon and look at the left now. You are holding it. So the right balloon comes out. Holding the wire. Okay, so now let us concentrate on the left. Shall we go to the LAO projection? Let's look at the left pulmonary artery measurements, Pramod. Left pulmonary artery measurements.
To the 14.
Yeah, correct. I think here. Yeah. See here, if you see that, it's a long course. See, from the beginning,
4,
it's almost, yeah, more than 3 to 4.
3 to 4. So we go for a 10 into 4 centimeter stent.
I'm thinking about it.
The length is probably again wrong here. Like when we see.
Yeah. Can you show that angiogram again? Yeah. See can you freeze the image and show? Go back a couple of frames. Correct. Next frame. Correct. So here, if you see,
Again 4 markers.
it's almost
3.5, more than 3.5 markers.
So I'm considering about. Shall we consider a 10 into 4 here?
10 into 4 should be fine.
10 into 4 because the length. Just empty the contrast. Let us see the number of holes. Yeah. Now you start going onward. Okay. Next frame. Enough. So here it's 1, 2, 3. Yeah, definitely. It looks like almost 4. We have to capture that LPA origin as well. The LPA origin is now in this frame exactly below the first sternal wire and above the sheath tip. Can you see that?
Yes, sir.
So from that point onwards, we have to capture it. So let's have a picture. This is LAO 51. Can we go to LAO 51?
With the RPA stent, if you do an angiogram, it might give a better idea. Like with the relation to the stent, we can see how far we have to come.
Yeah. So
Position.
let's lift the patient. Yeah. Okay. Now let me put the marker pigtail through this sheath. Can you hold the wire? Can we get one mag on this? Yeah. Can you bring the table towards me and towards you? Correct. Freeze it. Okay. Now let us carefully assess. 1, 2, and 3. Next frame. Yeah, I think 3 should be enough. Right? You see that? It's next frame. Here it has started. See, there are about. So let us see from the distal marker, the third marker. At the level of third marker, the PA has started bifurcating.
Yes, sir.
And so, if you take from that third marker onwards, 4, 5, and 6, so it's almost 3 centimeter. So let's take a. In fact, you observed in your CT that the left pulmonary artery was a little bit more tighter, smaller. So let's start with the 8 into 30 formula on the left, and then progressively keep enlarging it larger and larger. So we are going to be taking an 8 into 30. So I'll take out this marker pigtail that we have introduced into the sheath. So this is a 8 millimeter diameter, 30 millimeter long, and
no inflation.
again with the protective sleeve we are going in. Advancing the stent.
I think the clip there was the marker for the distal end.
Can we see that? Can we see the angiogram once again? Yeah. The distal clip is roughly the region of the branching, right?
Yes, sir.
Okay, I agree with you. So I'm going to peel back the sheath. It's going a little deeper. I will come again on pressure guidance. So I'm connecting the left pulmonary artery sheath to pressure. So we are recording low pressures now. It indicates that we are still not opened out the stenosis. So now I'm coming. We are beginning to have higher pressure recording, right?
Yes. Again.
So I'm going
100
to.
scale.
I'll make one angiogram at this point. Distally, we are fine.
Only we have a good pressure, higher pressure already. Even at this point, we have a higher pressure.
Yeah. So proximally, I will expose the. I have now exposed the last strut. We have another, within 5 minutes, it's going to be over. Can you go to epicranial? Epicranial, full cranial, maximum. So here,
Looks nice. And this the narrowing also is shown very well.
yeah,
It's better than whatever we saw in the.
yeah. So now what we'll do is, I'm going to peel back the sheath a little bit more. I think we are ready to go.
Yes, sir.
Keep going.
Okay. I'm inflating.
Yeah, just go rotation.
Yes, sir.
Yeah. Go to 10
Going
or
up to
12
10
atmospheres.
atmosphere now.
11.
11, 12.
Okay. Now deflate. Since we have decided to post dilate this,
Okay.
let's get a 12 into 2 Mustang ready. It's fully deflated.
Fully deflated.
So can you hold it? I'm again putting in the sheath inside. Oh, the stent is moving.
Oh.
Once again. Let's. Can we see whether show the previous picture? The previous. Did we record the inflation? Okay. So at this point, the stent is actually flush with the other pulmonary artery. So can you hold the wire? It's fully negative, this balloon?
Fully negative.
Okay.
No, it is possibly there only.
No, approximately it has moved more distally. More distally. You see that? The previous picture you show? Yeah. Not here. The previous one? Yeah. Here, when we are expanding, the proximal end of the left pulmonary artery stent is on horizontal level of the proximal end of the right pulmonary artery. Let's see it. Here. It's at horizontal level. Or if you look at in relation to the sternal wire, it's below the sternal wire. Show the next picture. A little bit of migration. So what we need to do is probably, let's get a 12 into 2 Mustang balloon. Another 12 into 2 Mustang balloon. We'll go across, catch the stent and slightly withdraw. Okay, we are holding it tight. This is fully negative? Okay. Out. Hold everything intact. So it's a 12 into 2.
12 into 2.
Central lumen flushed. Yeah, that's fine. I'll connect to the inflation device. Can you? So I'm on the proximal part of the stent. I'm going to unsheath now. I don't want to go distal. Yeah. No, take away the negative. There is no need for negative.
Yes.
Okay, slowly keep inflating. As soon as you grip the stent,
Yes.
I'm going to slightly drag it down. That's it. That's it.
Yes.
That's it. Okay. Now go for a full inflation.
Maximum inflation. I'm going increasing to 6, 8 atmosphere, 10, 10, 12, up to maximum 14.
Okay, deflate. The distal part of the stent, we'll try to enlarge it a little bit more. So let us wait for the balloon to get fully deflated. Once it gets deflated, we'll take the, let me have a look in the meantime of a pulmonary angiogram through the side arm of the sheath. So we'll just go inside distal, inflate it full.
Going for an inflation again.
Yeah.
Inflating to 2, 4, 6, 8,